inflammation presentation is on meningitis. The authors of this presentation are Sophia Jensen, Alejandro Laranaga, Andrea Sanchez, and Adrian Ward. Hope you enjoy.
Meningitis is an acute inflammation of the meningeal tissues that surround the brain and spinal cord. Meningitis can be caused by either bacteria or viruses. Streptococcus pneumoniae and Neisseria meningitidis are the leading causes of bacterial meningitis. Neisseria meningitidis has at least 13 different subtypes, with 5 of them causing the most cases. The organisms gain entry into the central nervous system through the upper respiratory tract or bloodstream. The inflammatory response increases cerebrospinal fluid production and increases intracranial pressure. The purulent secretions spread to other areas of the brain through the cerebrospinal fluid and cover the cranial nerves and other intracranial structures. The most common cause of viral meningitis are enteroviruses, arboviruses, HIV, and herpes simplex virus. Enteroviruses are most commonly spread through direct contact with respiratory secretions. The key signs of meningitis include fever, severe headache, and neck stiffness. The other signs include photophobia, decreased levels of consciousness, and signs of increased intracranial pressure. Coma can be associated with a poor prognosis and occurs in 5 to 10% of patients. Seizures can occur in 1/3 of cases. The headache caused by bacterial meningitis becomes progressively worse and may be accompanied by vomiting and irritability. If the bacterial meningitis is caused by meningococcus, a skin rash or petechiae may be seen on the patient's trunk, extremities, and also the mucous membranes. Viral meningitis manifests similarly, with patients having headache, fever, photophobia, and stiff neck. The fever is usually moderate to high.
The diagnostic tests that are used to diagnose meningitis are the use of imaging, spinal tap, and specimen cultures. The first diagnostic test we will be discussing is imaging. A CT scan or MRI of the head may be performed to show if there is any signs of swelling or inflammation. The CT scan may show an increase in intracranial pressure, which is a positive sign of meningitis. The scan may also reveal hydrocephalus, which is a fluid buildup within the brain. This occurs due to reduced CSF flow from scarring of the meninges membranes. A CT scan or X-ray of the chest and sinuses may reveal signs of infection. A CT scan must be done before a lumbar puncture to rule out an obstruction in the foramen magnum in order to prevent a fluid shift resulting in herniation. The primary diagnostic test used for diagnosis of meningitis is the spinal tap, which is also called the lumbar puncture. The CSF obtained from the spinal tap is cultured, and its results reveal a positive or negative diagnosis of meningitis. The third diagnostic test we will be discussing is specimen cultures. Specimens of the nasopharyngeal secretions, sputum, and CSF are used for culture. These specimens are used to determine which organism is present. A gram stain is also done to detect bacteria. There is one white blood cell type that is most prevalent in bacterial meningitis, which is the neutrophil. The CSF obtained from the spinal tap is what is primarily used for a positive diagnosis of meningitis. The CSF will reveal increased white blood cell count, decreased sugar levels, and increased protein, indicating the presence of the condition. Next, we will be discussing the medications commonly prescribed for bacterial meningitis and collaborative care.
The medications most commonly used to treat bacterial meningitis are going to be IV antibiotics such as penicillins or cephalosporins. Typically, these are not given until a culture specimen is obtained. The culture will help determine if the infection is bacterial or viral in nature, and that'll also help determine whether the use of IV antibiotics is needed or not. Adjunct therapy, such as the use of corticosteroids like dexamethasone, can be used with the IV antibiotics. That can be given before or with the first dose of the antibiotics. What the corticosteroids will do is help reduce meningeal inflammation related to the immune response. The body has an exaggerated immune response to an infection, and that can lead to cerebral edema or neuronal injury. Corticosteroids are immunosuppressive, so they can help control that exaggerated immune response. There are also medications that can be used to relieve symptoms of the meningitis, such as headache, pain, fever, increase in intracranial pressure, and even seizures. Codeine, an opiate analgesic, can be used to reduce incidence of headache and pain. Acetaminophen or Tylenol can be used as an antipyretic to reduce fever if the patient has a fever above 100.4. Mannitol, an osmotic diuretic, can be used to decrease intracranial pressure and also reduce the likelihood of seizures or headache as well. There's also anti-seizure medications such as Dilantin and Keppra, which can be used to avoid that. As far as collaborative care, the physician can provide orders for medications, therapies, and even more diagnostic tests. The nurse and the UAP can also perform certain modalities to keep the patient comfortable and monitor their progress. Frequent monitoring of vital signs and level of consciousness will be important. The vital signs can be taken by the UAP. Keeping track of these vital signs will help note any drastic changes, and level of consciousness can also be used to help evaluate the patient for signs of increasing intracranial pressure. Monitoring intake and output would be important for a patient experiencing a fever. Fever can lead to insensible fluid loss through diaphoresis. Fluid replacement may be necessary if that's the case. That's why it's important to monitor those. Slightly elevating the head of the bed can help relieve some of the head and neck pain associated with the meningitis, and also help keep the patient comfortable. Keeping the patient in a nice dark room will help reduce photophobia, which is another potential symptom of the meningitis. This can also ease symptoms of delirium and hallucinations. If those are present, it's a good way to lower stimulus in the room. Maintaining adequate nutrition is also very important. That can be done by the physician and the dietitian if necessary. The fever can increase the metabolic rate in the patient, leading them to use more calories than they're actually taking in, and this would lead to inadequate nutrition that, paired with fluid loss, may lead to problems with electrolytes. Enteral nutrition might be required if that is the case.
Now we're going to talk about 3 nursing diagnoses related to meningitis. Acute pain related to headaches, as evidenced by the patient complaining of a 10 out of 10 pain. decreased intracranial adaptive capacity related to increased intracranial pressure as evidenced by unequal pupils. Hyperthermia related to infection as evidenced by a temporal temperature of 40 degrees Celsius or higher.
Here are some of the potential complications that can occur along with meningitis.
Increased intracranial pressure is one of the most common potential complications of meningitis. Increased intracranial pressure can lead to optic nerve compression, which could potentially cause blindness. Increased intracranial pressure can also lead to ptosis, unequal pupils, diplopia, tinnitus, vertigo, or deafness. And increased intracranial pressure also leads to an altered mental state. Non-communicating hydrocephalus, which is also called obstructive hydrocephalus, is another potential complication from meningitis. Non-communicating hydrocephalus occurs when the flow of CSF is blocked along one or more of the narrow passages connecting the ventricles. Headaches are another potential complication associated with meningitis. Headaches typically persist until inflammation and irritation resolve. Waterhouse-Friderichsen syndrome is another potential complication associated with meningitis. It is defined as adrenal gland failure due to bleeding into the adrenal glands, and it's commonly caused by severe bacterial infection, such as meningitis. This syndrome is manifested by petechiae, disseminated intravascular coagulation, adrenal hemorrhage, and circulatory collapse. DIC and shock are the most serious symptoms associated with Waterhouse-Friderichsen syndrome.
Thank you for viewing our presentation, and we hope you enjoyed.